Thank you, everyone, for joining us for another Learning Lunch hosted by Format Approved. My name is Brian Johnson. I'm the Senior Director of Online Education with Format Approved, and I'll be your moderator today. Today's Learning Lunch title is Meaningful Use is Not Going Away. What is in store in 2015? We are joined today by Joy Rios. Joy is an expert in both meaningful use and EHR proficiency with years of real-world experience in meaningful use attestation, EHR implementation and optimization, and more. She keeps very busy with writing and curriculum design, attestations, PQRS, meaningful use. You couldn't ask for a better expert on this subject, so thank you for joining us today, Joy.
Sure, my pleasure. Thanks for having me.
All right, so before we get started, I'll go over some housekeeping notes. I'll let you all out there in the audience look at the questions we're going to cover today to give you a roadmap. Just so you know, you can ask questions of Joy at any time during the session by entering them into your chat area. We save those questions for the end of the presentation, and then Joy will answer as many as time allows. If she doesn't get to your question, she'll send you an email that we'll send out via follow-up. People always ask us for the slides and the video recording. We do both for these sessions, and that will also come via email follow-up. So if you want to get your hands on the slides or you want to share the recording with colleagues, look in your email inbox for that sometime later today or tomorrow. All right. I think that covers the basics. Let's begin. So, Joy, thank you again for joining us. Maybe it's best to start if you could give us an overview of where things stand now in the meaningful use universe.
Sure. So we are in an interesting place. We've gone through stage one and many people have, attested to stage two, but there's quite a bit going on with the government and just planning for the next 5 years. So as we know, the Meaningful Use program came out of the HITECH Act, which was implemented in February 2009 and started in 2010. And at that time, they had created a 5-year strategic plan for health IT, and it was the 2011 to the 2015 strategic plan. Well, can you believe it's already been 5 years, and now they've updated that. So that was just released in November. So now we have a new federal health IT strategic plan that looks out to 2020. And then in conjunction with that, there's been a release of a draft of an interoperability roadmap. That aligns very well with stage 2 of meaningful use and the whole concept of sharing health information. And then just a couple weeks ago, I think January 29th, they also released, the ONC released some information about some reporting changes that will happen in 2015. So I'm sure everyone's excited to hear about that. We'll be going over what was announced, and we'll find out soon what the final rule is. And there's also draft recommendations of what's going to happen in stage 3 of meaningful use. And then, of course, there's this conversation going on about transitioning from a pay-for-services model to a pay-for-performance. And though I'm sure many folks have started to get those letters in the mail talking about penalties getting into place, so we'll talk about what that, where they come from, how you can, get started to avoid those penalties, and then just talking in general about the overall, of the different quality measure programs, what penalties are in place, and how can you strategize to not receive them. So there's plenty. There's plenty going on in the MU universe.
So let's talk more about the Federal Health IT Strategic Plan. What parts of it relate to meaningful use? There's a lot in there, right?
Yeah, so this plan, it's the update of the one that was released in 2010, and it's essentially the 5-year forecast. So they have 5 main goals of this plan, and the first goal, the number 1 goal, is to expand health IT adoption and use efforts. So that is an interesting one because they're talking, that it's directly related to meaningful use. They're trying to, not just accelerate, they've already accelerated the adoption, but they want to build on that. And to do so, they're having a greater emphasis on telehealth consultations, and also mobile health. So look for that in the coming years and seeing how that gets incorporated into the whole health IT conversation. And then ONC is definitely expecting, they state it right in their plan, that they expect the number of professionals and hospitals to, who demonstrate meaningful use to increase significantly in the next 3 years. So that's kind of our first hint about meaningful use not going away. And then, they're talking about this whole digitization of health information allows us to share, this information that's high quality. They need it to be accurate and relevant information so that we can connect care and really empower individuals to manage their own health and their well-being. So that's essentially where some of this mobile health and wearables and telehealth, also kind of comes into play. So that's goal number 1 of the strategic plan, and then let's continue. Yeah.
So what else is there? There's goal 2 on here. Tell us more about that.
Sure, and I'm not going to go over all of it. There's 5 main goals, and you can read the plan on your own, because I do give those resources. But the second goal has to do with advancing secure and interoperable health information. So, taking into account that we're collecting all this information, digitally, their goal is to focus now on sharing that information and making sure that it's shared in a safe way. So this particular goal aligns really well with the interoperability roadmap, and their hope is to stimulate secure and seamless sharing. So right now we have plenty technologies that talk to each other, but I think that everyone's experience is that it's certainly not seamless. It's not, a push of a button. It's super easy. So that's what they are focusing on, and that involves building on the foundation that we've started. So, you're going to see a lot of changes in technical and vocabulary standards. So that's something that a lot of the EHR vendors and other types of technology developers are going to be concerned with. We'll probably see another change in the certification standards for electronic health record technology. We'll see differences in, privacy and security protections, and certainly there's a lot of work still to do in this area. But ultimately, they want to increase the percentage of, individuals, providers, and public health entities that can send, receive, find, and use health information across the care continuum. So that's that goal.
Yeah, it does seem like they're really focused on getting interoperability to work the way it's been promised to work for a while. It's been some time that they've been working on building better interoperability, and I know they've made a lot of progress with Stage 2, but they seem to still be very focused on getting that part of the puzzle to fall into place.
They're certainly making a concerted effort in that area, which I think is a good thing, because especially if they're requiring people, as part of participating in meaningful use, to be able to have their technology, the requirement of the individual provider is that their technology talks to other technology from other facilities. Well, it's not that the provider can't make that happen necessarily. If they don't work, they don't work. So that's why we've got to get in industry-wide, people speaking the same language. I think that's exactly what, they're focused on, especially with this interoperability roadmap, which is our next topic.
All right, well, we already sort of touched on it, but tell us more about the interoperability roadmap.
Yeah, sure. So this fits right in line with the strategic health IT plan, and interoperability matters for a lot of reasons. It's not only for just the sake of meaningful use, clearly, but individuals, providers, we all need access to right information. We need it at the right time and in a manner that we can use it to make decisions and impact, the decisions that impact our health. So wherever we are. And statistically, a typical Medicare beneficiary receives care from 2 primary providers and 5 specialists each year. So imagine if those doctors, if there's 7 providers that can't share information, you know, they're really looking for that in particular. Another interesting statistic that I read is that only 10 to 20% of health outcomes are attributable to healthcare, and so information really needs to be flowing both inside and outside of the care delivery system to support people in, you know, making decisions about their health. So the goals associated with this particular roadmap, their 3-year goal, they're looking for by the end of 2017, the majority of individuals and providers will be able to exchange, you know, common sets of clinical information. So that's not too far away. They should be able to, whatever is created, let's say within your EHR, should be seamlessly shared with somebody across, you know, the country or the city or whatever, to use that information. And then their 6-year goal, so by the end of 2020, they're looking to start incorporating information from other sources. So we're looking at wearable technology, implanted technology, and other, you know, mobile health devices to be connecting to certified EHR technology. So we're going to see a real focus on patient-generated health data, and that is all part of the conversation, you know, and the effort to empower and engage patients. So it's going to be an interesting 3 and 6 years.
All right. It's interesting to see, you know, there's been all this concern about patient portals and getting people to use those. I think those concerns, in my opinion, are a little overblown. I think that there will be better use of them than people expect. But you do wonder then about how many people are really going to use mobile health and wearables too. I mean, that would be a fair question.
Yeah, I agree. And I wonder how many people are going to be, you know, so for example, you have your Fitbit results or any other type of, you know, health tracking. I wonder how many people actually want their doctors to have access to that information. But maybe if you have a care plan or some long-term goals with your health, that might be a way to stay in better touch, you know,
maybe
with your doctor.
I mean, you can certainly see it as part of care for a chronic condition, but for average, everyday people, you wonder.
Agreed. Yeah, I agree with you, but we'll see.
Well, one of the big subjects of interest lately has been this question of meaningful use reporting relief. We all know that there was a 90-day reporting period in 2014. What have you been hearing about 2015?
Well, thank goodness ONC, they basically released an announcement on January 29th that set their intentions for 2015. And they basically have 3 things that they intend to do, although none of it is officially final just yet. So just so you know, this has been their, you know, this is what we plan to do, and we don't know when it will be official. I'm hoping by the end of the month, certainly sometime within, you know, the next, hopefully not any later than March, so that it's not affecting people's, you know, reporting start dates and that such thing. But what they're looking to do is interesting. They want to realign the hospital reporting period to match the professional, the EP reporting period, so that it's based on the calendar year. Currently it's on the fiscal year, so that's October through September. I imagine that they want to do that just for simplicity's sake. There's probably, you know, no need to have an additional time frame to coordinate around. If you can get everything aligned, I think that that would make things easier for people and them administratively, I imagine. And then they also want to modify, you know, reduce some of the complexity and lessen some of the reporting burdens. Now, we all know that there's been a lot of struggle with some of the reporting requirements, and people have been, you know, giving them feedback very loudly and very clearly about like what they don't like. So this is their way of saying, we hear you. and we're going to try to do something to fix it. Now, they didn't state specifically what that means. I am personally hoping for more of a graded scale instead of a pass-fail. I'm hoping that, if there's 17 core requirements, that if you meet 16, then you're still eligible to, for some sort of benefit or not, subject to the penalties, something along those lines.
That's an interesting idea. It is all or nothing at this point.
Yeah, and that's a lot of pressure for people, especially when you are putting so much, your organization through so much change, and say you succeed at the majority of it, and if you fail in one area or stumble, it's as if you did nothing. And
right. So the whole point of this is to get people to meaningfully use the EHR. If they do 95% of what they're supposed to do but fail in the last 5%, well, they've still achieved 95% of that benefit. So I think that would be a great idea.
Yeah, and I hope that it's a change in how they define success.
Yeah.
I don't think that for most people, if you reach 99% of something, that's pretty successful attempt. So this is by no means any official, statement. That's just
understood. It's kind of speculation and hope.
And then lastly, they intend to shorten the EHR reporting period in 2015 to 90 days to accommodate these changes. So we're going to find out what those changes are, and then I imagine that it will also, again, align to that calendar year quarter. So
now, why did they I'm sorry to interrupt, Joy, but why did they want to realign hospital EHR reporting?
They didn't really say why they wanted to do that. I think that I would imagine that it has to do with just deadlines and timelines and the administrative side of it. It's probably easier to track, one program, and I imagine that their help and support desks, those people are, those poor people are so busy with people calling in over questions and trying to find the right information on the CMS website, and they've got dueling
that's not easy.
Information. That's got to be really tricky. So
now, when it comes to reducing the reporting period to 90 days, does that have anything to do with stage in the proposed rule, or is it's just, if you were ready for stage 2, you would need to do stage 2, but it'd just be for 90 days?
That's what I think it is. They didn't state that it is, people that are only participating in a particular stage. I mean, we know that first-year participants only have 90 days, and that can be any 90 days, but everybody beyond that has to do their 90 days that align with the calendar year quarter.
Right.
I think that, I don't know, we're going to see what those changes are and what, But one of the reasons why I think that they go back to 90 days, and I'm going to repeat myself in just a few minutes, is that I think that studies show that, what providers and what organizations can accomplish in 90 days. They've already created a routine. They've created a habit. They've instilled some sort of behavioral change, and that's the kind of thing that after that 90 days, it typically continues. It's not like they, you start a whole new workflow and then you stop it again.
Well, and that wouldn't make any sense at all then, because you're supposedly getting ready for next year too at the same time, when you shouldn't expect it to be 90 days. And why would you just throw away all that hard work you did? So really what the 90 days is to give you a later start in the year to get going on this stuff if you need it, but not just like, I'm going to do the second quarter and then forget it. I'm going to forget about MU altogether.
Yeah, and I think it's a way for people to build up their skills, so as they're learning their EHR or using it in a different way, you can't really, if a lot of people reported the last quarter of 2014, so from October, November, December, and if they have a 12-month reporting period expected for this year, then they really have no room to make any mistakes, or very little learning curve. So I think that they're acknowledging that and just offering more time for people to adjust their workflows and get up to speed. which good for them. I'm glad they do that. They're doing that.
But just a caution, they haven't issued the final rule yet.
Correct. Yeah.
All right. So what options are available for MU participants in 2015 then? What does it look like?
Here I just wanted to point out the starting points. So, you know, if you are looking for incentives and you still have not started meaningful use, the options are getting fewer and fewer. So Medicare, on the professional side, 2014 was the last year to start, at least for the incentive. So if somebody starts, you know, a new organization and they have providers who've never participated in the program, their option as of 2015, this year, would be to enter into the Medicaid program. So this year, basically, we're going to see people that are either finishing their, you know, their second year of the program, which could be both Medicare or Medicaid, or if they're in, you know, they did stage 2 last year in 2014, this would be their third year of the program. No, they could be in their third year of the program this year, or if they're in their fourth, then it could be their second year of stage 2. And then eligible hospitals, this is something that was pointed out recently. They can still earn an incentive payment and avoid a 2016 penalty. I think that there was an extension that was made. So for first-time participants in the Meaningful Use program, if they have not started yet on the hospital side, if they begin their reporting period no later than April 1st of this year and attest by July 1st, then they have the option to still enter for the incentive payment. But that's essentially the last of the first year participants that are eligible to start the program. So going forward, if you know folks or if you are part of a facility that have not started, have not started the Meaningful Use program, you should be looking towards the Medicaid EHR incentive program on that side of things.
All right. Well, let's talk about stage 3. So we know that stage 3 got pushed back to 2017, but we don't know very much about what's going to be in it, or do we? Tell us more about what may be on the horizon.
Sure. It was back in August, there was a draft recommendation for stage 3 that was released. And I have a link to that in the resources section, so you can start to see where their mind is, where the ONC is thinking about, and how they want to go forward. And pretty much what they're doing is incorporating the lessons that they've learned from stage 1 and very soon from stage 2, and then incorporating those into stage 3. So what does that mean exactly? Stage 1 showed substantial increase in the adoption rates of EHRs, which makes sense. And that implies by the time that stage 3 is implemented, we'll have created a critical mass of users and data in electronic form. So they're thinking, okay, well, once we have all that information in electronic form, then it's, instead of having the goal be collecting that information, now it's how do we use it? How do, what do we do from there? So we're going to start to see a lot of different types of requirements that are not necessarily focused on the collection of information, because they expect that to already be happening. The other things that they stated in this draft report is that what's happening with stage 1 is creating network effects. So benefits of things like patient engagement and health information exchange, those types of goals, they don't just benefit the users. They benefit, of the EHR system. They benefit everyone. So there's the rising tide floats all boats analogy that kind of fits right in there. And then what we're seeing is that the thresholds that were in place for stage 1, the ONC found that across the board, these were consistently exceeded. So a lot of people didn't just barely meet the threshold. They went far past them. So collecting, and then a lot of the stage 2 thresholds, they went even farther, right? So we saw things like the change from demographics and smoking status and vitals, several others that went from a threshold of 50% of unique patients going up to 80%. And what they find is that once that habit or routine or workflow is in place, they find that people continue, like we were saying, that it's continued. So I think what they're thinking about doing for stage 3 is condensing a lot of those objectives, like specifically demographics, vitals, smoking status. They may include those as part of the clinical summaries, that need to be reported to the patients, giving them access to their health, that you won't necessarily need to report on each of those specific line items, but they will be assumed that information will be collected and included in the clinical summaries.
Well, it seems analogous to me to clinical quality measures, which were a core measure and then sort of just became a requirement of the program, apart from core measures.
Yeah. I think that they just have the expectation of like, okay, well, if you've already shown that you can meet 80%, an 80% threshold, then it's not as necessary for people to report on those things. So, okay, that's now habit, and that's now changed behavior, so we don't necessarily need to track it as closely. So I think that they'll start focusing on, again, like the use of that information.
All right, well, let's look at other implications to consider for stage 3.
Yep. So they've seen the consistent use of the EHRs over the years. They see the gains. They expect those gains to continue from stage 1 and stage 2. They've heard, ONC's heard loud and clear what the burdens are for people in the reporting requirements. And so, again, we can look forward to simplified processes and a reduction in reporting requirements altogether. Hopefully simplified meaningful use objectives. And like I said, so, not necessarily requiring EPs to report on their percentage of patients who've had their smoking status tracked or their vitals. It would just be implied that that's part of their record already, that providers should be doing those things. And then with everyone kind of going through the same struggles across the country, there's more resources than ever that are available to people. So for regional and local, there's going to see people have more resources that they can use when it's time to implement changes. So, and then lastly, this is kind of gearing into our next conversation, that we're going to see them touch on these new payment models and rewarding good behavior and this whole, the focus on value. And so to date, you were just mentioning the CQMs, there's not been any thresholds for the clinical quality measures. It would not surprise me if we started to see that in place of reporting these particular thresholds that I was mentioning, that we'll start to see a threshold for some of the quality measures, so that people, because again, they're transferring from the difference of collecting information to now, what do we do with it, and how can we, improve performance either year to year, like compared to ourselves or compared to our peers.
And so just to sort of amplify and clarify your point here, at this point, to date, CQMs have been about recording data, but the next obvious move, and this is already a part of PQRS, is, at least for some folks, is to take that information and say, well, you should be achieving this goal via CQMs.
Right. And, I think that a way to simplify the thought process around that is to think of, it's a pay for reporting. Currently, clinical quality measures has been, it's kind of a pay for reporting where you're only required to report. There's no threshold, there's no minimum requirement, and it may transition to a pay for performance. So.
All right. Well, there's certainly been a lot of talk about that. And that does sort of blend in with our discussion of PQRS. What other programs should providers keep in mind as they plan for the year?
Yeah, well, I'm sure plenty of offices and facilities got those letters that were telling them that, 2015, this is the first year that we see the stick. From our carrot and stick analogy, people are starting to see negative payment adjustments based on their decisions that they made. So to clarify, the penalties that people are seeing this year in 2015, that's based on the decision that they made in 2013 to either not participate in certain programs like PQRS or Meaningful Use. And so it's there's a 2-year time lag. So 2015, right now we're talking about, what happens within this performance year will affect the payment adjustments 2 years from now in 2017. And up until now, so we're kind of transitioning to this PQRS, so the Physician Quality Reporting System program. It's been around since 2006 or 7 as a voluntary program, and this is the first year that providers are starting to see penalties of it.
And I think this one is just really the stealth program. Not that there isn't, CMS talks about it all the time, but that people just have not paid that much attention to it, at least a lot of folks. I remember what are the participation rates, like somewhere
30%,
around 30%, yeah.
Yeah.
And so now the stick has arrived and people are like, what do you mean PQRS is required?
And the thing is, this program is by no means straightforward. So if anybody finds it confusing, you're not alone, because they have several different reporting methods. A lot of people think that they can do multiple. So, I mean, you can participate in the program by using submitting certain claims data. You can use a registry. They've now aligned it so that you can use an EHR for larger groups. They have a web interface. They're now including the CG CAPS, so survey modules from the patient experience, talking about what was their care like, when they were seeing that doctor. And it's very similar in some ways to the clinical quality measures of the Meaningful Use program, where in order to earn the incentive, which was relevant last year, there's no more incentives available this year. Now they're talking about, okay, so you can avoid a penalty. And in some ways it does align very well with, again, with the clinical quality measures. But then in addition to all of the different ways that you can report, there's also a variety of changes based on the size of your organization. So the rules kind of change for larger groups of 100 or more EPs. Then there's groups of 10 to 99 that have their own set of rules, and then from 1 to 9 that they face something different. And so if you transition to the next slide, I think we can have a conversation about where PQRS and the value-based modifier program come in. So this is another area where it gets kind of confusing. And the way that it works is when you participate in the PQRS program, so let's say that you're doing EHR reporting, so it aligns perfectly with your clinical quality measures. You've got 9 measures, they cover 3 domains, you submit them through your EHR. When you submit for PQRS, you're automatically enrolled in the value-based modifier program. So there's no separate enrollment or participation guide for this value-based modifier program. And to kind of give you an idea of the differentiator between the two, the PQRS side of it is essentially the pay-for reporting that we're talking about, and then the value-based modifier side is essentially the pay for the performance. So they essentially, the PQRS side is where they collect all kinds of data from every organization across the country, and then they pretty much create benchmarks. And then so they look at, okay, based on these 9 quality measures that everybody's submitted, how is everybody doing? They divide it up by specialty, they divide it up by size, and then they give you it takes them about a year and a half to go over all of, a particular year's data, and they essentially put people in tiers. So based on your specialty, based on your size, even based, I think, on your region, they'll say, how are you doing compared to that national average or the national mean?
And that calculation considers both cost of delivering care and the quality of the care.
Correct. Yeah. So those quality measures, that is where they take on the quality. They call it the quality composite. And then they also look at the claims data for all Medicare beneficiaries, and they see how much did you actually spend per Medicare beneficiary. And so they put those two together, and then that information helps them figure out where does the provider land, or where does the group land. And if they are shown to have high quality at a low cost, then that is, high value. That's the best you could hope for, that you're offering a lot of benefits, not costing very much. And so there actually is an incentive for that, and then they're rewarding people if they end up in the the highest tier.
So you get some extra cash from the government if you achieve that.
Right. Up to 4%. There's at least based on 2015, for that value modifier, there's a possibility of an additional 4% incentive for being a top performer. But the flip side of that coin is that if you show that you're, either you don't participate at all, if you ignore the program altogether, you're going to get a penalty, just because what they do is they assume that if you do not want to report your quality measures, then they just assume that the quality you provide is poor, and so they put you in the bottom tier. And then, at least for PQRS, and then that value modifier gets added as well. So it's pretty much an amplifier. That the value modifier serves as an amplifier or a magnifier of what you submitted for your quality measures for PQRS. And as I guess it's their token gesture. What they've decided to do, especially for groups of certain sizes, is that because groups that are larger, that have 100 or more EPs, they've been subject and part of this program for a couple more years because it's been mandatory for them, and so they see all of the negative payment adjustments. For groups of 10 to 99, they've changed it so that, remember we've got that 2-year lag. So if they show that they don't have a great performance, they're not going to give them an additional penalty. So basically by participating in the program, it just means you're avoiding the PQRS penalty, and if you happen to be a great performer, then you're also eligible for the incentive. But then they give you a little bit of extra time that says, if it turns out you were shown to be a poor performer of those quality measures, then you don't necessarily need to pay that penalty. It's about one per year. And then now, for the 2015 year, they're basically applying that same set of rules to groups of 2 to 9 and also solo practitioners. So that's essentially by 2018, that and based on 2016, by next year, we should start to see real transitions into, this is essentially how they're making the change from, pay for service to pay for performance. And this is just one, I'm sure, of many other very complicated ways that they're doing it, but this is one.
So these are relatively small adjustments, but these will be the first quality-based adjustments most providers ever see. So it's kind of a way to get them acquainted with the idea before they take it to the next level, which I know is part of the plan.
Well, I think part of it is, when you know better, you do better. And part of with the EHR incentive program, it really gets allows us to see insight into a practice. You say, what are we doing? What are we not doing? I mean, if everything is functioning at its full capacity and people are using the systems in a way that, you know, hopefully is helping, then they can see and look at, like, okay, well, where can I improve? And then that's what they're starting, you know, the whole point is to be looking at your data or letting the data speak to you to help you make better decisions, like, okay, I need to, you know, focus on this particular patient population, or do a, you know, additional screenings on you know, for something in, you know, particular. But and that's part of the reason why, and I was just reading about this yesterday, they're having, it's not necessarily your performance in relation to, like, so if we fast forward, say, to 2018 or 2019, and you get your quality resource use reports back, which is essentially telling you how you did compared to everybody else, over time, they're going to be rewarding people for just doing, you know, comparing them to their own self. So if I say got a, you know, 50% in 2016, and then I got, you know, brought my numbers up to, say, 70% in the next year, then you know, the fact that I was able to improve my own metrics, that, you know, 20% is worthy of a reward, even if that's not necessarily, you know, in comparison to how my neighbor is doing down the street. So it's interesting. It's pretty complicated, and imagine the amount of information that they have to sort through is got to be pretty daunting. But yeah, we've all got our work ahead of us.
So I think you've touched on this, but it's surprising to people when they hear this. So I'm glad that you included this chart. What are the total penalties that people could face from all the different programs if you add them up?
Yeah, so there's quite a big range. It's actually, you know, around 21%, you know, of the range, going, you know, of the incentives that you could earn, including the penalties that you can face. So for what people are doing this year and the penalties that they could face is actually, look at the 4 plus 2 plus 3, that's 9%. So if somebody did absolutely nothing in 2015, if they didn't participate in meaningful use or PQRS, and then by, you know, just by extension, the value-based modifier, they would be seeing a 9% cut in their Medicare Part E reimbursements. But the flip side is that if they are participating and they get, you know, high ranks, if they're top performers, or if they're just participating in meaningful use, again, that's it's all or nothing, pass or fail, then you get your incentives. So yeah, I think that they're making a statement, and it's very clear that this is, you know, quality metrics and quality programs are certainly, they're invested in it. ONC is interested in everyone, you know, doing better, and, you know, not just measuring their quality, but improving it over time. And I think that they're really trying to focus on helping, although a lot of people don't see it that way. But we've got a lot of people to manage, so I think that this is one way of being able to have that concerted effort. Do you have anything to add? What would you like to add?
Well, on that, I think you hit it, just that there's larger penalties than people expect. And then, of course, if they do move towards something like MIPS, which they have proposed, that would really be a large-scale shift to pay for performance. That would really change things dramatically.
Yeah, we'll see.
So what are some additional resources our attendees might find useful?
Sure. Well, I talked a lot about each of these today, and I just thought people might want to go to the source. So there, I've included one, the actual Health IT Strategic Plan in its full format, and then actually earlier this month, so February, I believe, 2nd and 3rd, there was ONC's annual meeting, in which they talked about the strategic plan and the interoperability roadmap. So I included two presentations. Those were both about the strategic plan and the interoperability roadmap with a little bit more detail and just kind of other insights that folks were talking about at ONC annual meeting. I included a resource to that reporting relief if somebody wants to see all of the information that was released about 2015 reporting, and which is different from Meaningful Use Stage 3. So there's a presentation that includes the draft recommendations. That one is extensive and very informative. It's kind of like looking at the crystal ball of what the next 5 years are going to look like, and you can really start to see what their focus will be on. And then lastly, I've included the 2015 PQRS implementation guide. This is very well done. I've actually, commend ONC for this particular document. It states pretty clearly what all the options are, how to go about reporting for PQRS, and they even include information on like some of the most confusing aspects of the program, which is a lot of the quality data codes, which you don't necessarily, for claims-based reporting. That is by far one of the more confusing aspects of that particular program. So they have some nice information there. I think that's plenty of light reading for people, I imagine.
Well, remember, members of our audience, that you'll receive the slides after our presentation where you'll be able to click on these links and get this additional information. We've got some questions from our audience. If you've been holding your questions, go ahead and ask them now, and we'll share them with Joy. We'll start with the questions we've already received. This is a rare opportunity to pick an expert's brain about PQRS or MU questions, so do take advantage. This first question is, can you clarify, EPs who haven't started MU yet, and their first year will be 2015, they cannot do Medicare MU, they are only eligible for Medicaid MU?
If they're looking for an incentive. If you want the incentive program, like if you want to see some incentive money, yeah, your option is Medicaid.
Right. So Medicaid, they have until 2016 to start, but for Medicare, the incentives are now gone. But you would still, it would make sense for some providers to start because otherwise they're going to face growing penalties.
Yeah. At this point, yeah, if you want, it's not too late to start the program at all. It's too late to start the Medicare EHR incentive for incentives.
Right.
So at this point, if you wanted to participate in the Medicare side, you would be participating for the sole purpose of avoiding that penalty. And actually, the other conditional piece on the Medicaid side is that it's important to look at the size of your patient population. So there should be a 30% minimum threshold of your patient population that you see that comes in as the non-Medicaid.
Right.
That doesn't. That piece is not the same in Medicare. That's one of the biggest differentiators between the two programs.
All right, so let's look at our next question then. What is a practice to do if the CQMs are not aligned with the specialty and are irrelevant, but they must meet a quota?
Yeah, that's a tough. Well, okay, that a lot of people face. So, one, I would work with your EHR vendor, understand what their plan is, because a lot of vendors, and I've mentioned this several times before, in order to get certified, they had to meet a minimum of 9 clinical quality measures. Whether that actually matches the clinical quality measures that the facility wants to track is debatable, right? So if you want to be tracking particular CQM measures, make sure your EHR vendor knows that, and then they can hopefully put a plan in place to implement that as soon as possible so that they can add that functionality to the EHR. If they do not plan on, including your particular preference of clinical quality measures, then I would say you need to submit 9. So maybe thankfully there's no threshold, but the minimum of, I don't believe that, it's for PQRS actually, that you can't report 0% performance rate. For the clinical quality measures, I believe you need to have at least a number in the denominator. You can't be reporting 0 as a numerator and 0 as a denominator. So that's where it gets tricky.
All right. Well, before we go on, we've got other questions, and we'll get to those. I just want to let our audience know that if you've appreciated this session from Joy, you should know that she has written formal accredited education with Format approved on meaningful use and PQRS. So if you're interested in attending our next live workshop that will be led by Joy, you can go to www.formatworkshops.com. That is the next upcoming workshop that starts on March 11th, and that is on PQRS, but it also focuses on how you can align your PQRS measures with your CQMs. And in addition to that, if you go to the top link on your screen, Format Training, you'll be taken to the Meaningful Use course that Joy has authored that goes through all of the information you need to understand to get a good grasp on meaningful use. We keep that course up to date. It's not easy with all the changes in the program, but it is something that we do regularly. And finally, I'll say that if you are interested in those programs, be sure you use the discount code FORMEDLearning to take a 20% off the retail price as our thank you for attending this session. All right, now back to a few questions before we run out of time. So someone asked as a follow-up, you can't report zeros for PQRS? You cannot?
I don't believe so. I think a 0% performance rate does not, they won't accept it. So you can report as like if there's a denominator, if there, so the way that it's tracking, at least when in your EHR, and if you spit out a quality measure report, it'll tell you how many patients could have been, would be included in the measure. So that would be how many patients are relevant for this particular measure. So you should have a number that's greater than 1 in that denominator. And then the second piece is what clinical action was taken on that patient population. So if you have something where the denominator was 0, if there were no patients that came in, well then there's no possible way that you could track if the clinical action was taken on 0 people. It would be, that's why a 0 numerator with a 0 denominator doesn't count. But if you do have a number underneath that line, then you can include it, even if 0, I have a client who doesn't do immunizations. So they are reporting some, a measures group, and one of them is tracking, how many immunizations were given to a certain patient population. Well, they have in the denominator the number of patients that it could have been given to, but since they don't provide that service, then it's still 0 at the top. So that can be submitted. It's okay, and you can still meet the requirements of the program if the clinical action wasn't taken, but it needs to apply to a population. It can't just be, this applies to nobody. Does that make sense?
Yeah. All right, so we have a question about the MAV, and so this may be one you might want to return to in writing, I don't know. The question is, please explain the MAV process in relation to the clinical clusters. Can providers report only a cluster that is related to their practice?
Oh, so this is new for 2015. Whoever this questionnaire is has been reading the new rules. Good for you. Okay, so the MAV is the Measure Applicability Validation. That is applied to only 2 types of reporting of quality measures. If you are reporting via claims or if you are reporting via a registry. It is only applied if fewer than the program requirements are. So remember, that's 9 quality measures that cover 3 NQS domains. If you report, say, 1 to 8 measures, or if you report on 9 measures that only cover 1 or 2 of those NQS domains, what they do is they apply the MAV. they apply that to say, and essentially it's kind of like an audit, similar to an audit, where they would say, could you have reported on more? And the clinical clusters, this is a new thing for 2015. So let me see if I can pull from my memory bank. What they do is they will take, they're looking at face-to-face encounters. So how, if you're reporting via claims or registry, how many of those patients were in there for an office visit, face-to-face, and then they're looking at measures that are clinically related. So similar to like a measures group where, for example, pulmonary, they have 5 different measures for COPD tracking, different information. Those are all clinically clustered together. They have a new set of lists of all the different clinical clusters. And to be honest, I think I may have to report back to this one in writing because it does get pretty detailed.
Yeah, it does.
I don't have a photographic memory.
Yeah, it's a pretty tough question, but it's a good one. So let Joy get back to you in writing on that one. So now here's a question about PQRS, and the question is, of the 30% participating in PQRS, do you know how many are hospital-based? But isn't PQRS for ambulatory-based doctors?
That's correct. Yeah, PQRS is it's not a hospital program. Hospitals have their own quality programs, and I have not been tracking those as closely. I typically work on the ambulatory EP side of things, and PQRS is only, the eligibility requirements is that they are not hospital-based providers.
Right. So here's a good question to wrap up on. It's the million-dollar question, and that is, how likely do you think it is that CMS will change the reporting periods to 90 days this year for meaningful use?
Oh, I think that they set their intention. I think it's very likely. I think that it's not just that's wishful thinking. I think that they stated very clearly, and if you want to click on that link when you get this thing, you can look at their announcement that says, our intention for 2015 is to reduce the reporting period to 90 days. So we're still staying tuned to get that official statement so that it's the final ruling. But yeah, I think that we can be conservatively 90% confident, that that's going to happen.
All right. Well, if we didn't get to your question, we're going to send those on to Joy, and she'll follow up with you separately. Remember that the slides and the video recording of this event will be sent to all participants as well. So look in your email inbox for that follow-up email. Remember that if you're interested in a formal education and meaningful use, you can go to formedtraining.com and take our Certified Meaningful Use Professional course, which was authored by Joy Rios. Use the discount code FormedLearning to take 20% off. Or you can go to formedworkshops.com to sign up for the next PQRS webinar, which starts on March 11th. Be sure to read Joy's regular column for Formed Approved. If you go to our website, formedapproved.com, and click on the Content tab, look under HIT Answers for her Ask Joy column. Visit that homepage to learn more about our upcoming learning lunches as well. There's a learning lunch box, is just similar to the one on your screen there, that you can click on, and you can see all of our upcoming webinars where you can learn more and register. Thank you so much for joining us today, Joy. It's a great pleasure to have you share your information with our audience.
Yeah, thanks for having me. It's always nice to share what I learn out in the field.
All right, and thank you to all of our audience. We will see you at our next Learning Lunch session.